Hello, and welcome to the last lecture of this course. Today we are going to talk about the multi-agency approach and cooperation between IPV and PSU professionals. As we have discussed, an IPV survivor who is simultaneously suffering from an addiction problem is in a particularly vulnerable position. Cooperation between different service providers should not only ensure that the woman receives all the necessary support, but ideally it should also eliminate the burden of going between different institutions. The first step toward an integrated approach to IPV and PSU services is screening and referral, coupled with ongoing contact and coordination with staff at the agencies where the woman is being referred. The screening process itself can be very helpful if conducted properly. For example, Ogle and Baer conducted a pilot experiment in an IPV survivor service agency using the Drinkers Checkup, or DCU, screening tool. As a result, 22% of shelter residents were identified as either engaged in heavy drinking or using illegal drugs, and they received corresponding referrals. In a similar manner, SA treatment agencies should screen all women for abuse that occurred during childhood and adulthood. However, referrals should always be presented in the form of an offer and not imposed on a woman. There should always be room for the woman to decide which treatment approach she prefers. The next step toward better integration of IPV and PSU services is multi-agency cooperation that helps to ensure ongoing contact and coordination between the agencies. There are two different approaches. The first offers parallel interventions, meaning that IPV and addiction are dealt with at the same time, but with specialists from different institutions. The alternative approach is integrated intervention, in which IPV and PSU are addressed simultaneously by specialists from one organization or as part of a single integrated service. One of the most prevalent examples of parallel interventions is known as MARIC, Multi-Agency Risk Assessment Conference, which was developed in the UK in the early 2000s. It is characterized by effective coordination of actions among relevant actors, each of whom plays a role in preventing and combating violence against women. Fundamentally, MARIC is a method of sharing information and overcoming organizational boundaries when providing complex services to clients. A major benefit of this form of cooperation is that it can be implemented immediately as it relies on the interactions of direct service providers and not necessarily institutional assessments. In MARIC conferences, which usually occur monthly or twice a month, representatives from various agencies and service providers come together to discuss high-risk cases. Typically, these can include police, judges, victim protection facilities, offices for youth and family, child protection, educational institutions, counseling centers, hospitals, probation and perpetrator programs, housing offices, etc. MARIC's operational principles include individualized follow-up strategy centralized by one service operating in a network of other services and professionals. Structured intervention with a clear definition of who does what and when according to the local protocol. Intervention designed according to the person's needs and the degree of emergency for all involved in the situation, including children or dependent relatives. Integrated databases with a unique file per person and strategic use of the relevant information, prioritizing secrecy and confidentiality in order to protect the survivor. However, MARIC also has limitations. As a general rule, only high-risk cases are brought up for discussion when there is a direct threat to a woman's security and immediate action is required. Therefore, in a wide range of cases, MARIC is not a good basis for sustainable cooperation between agencies. Another clear negative is that case-based approaches tend to be reactive, responding to problems as opposed to anticipating them. As a result, these approaches do not address system-wide or institutional barriers that can hinder cooperation. Another example of parallel interventions is offered by coordinated community response. It was first developed in 1980 in Duluth, Minnesota, to improve responses to domestic violence perpetration. CCR is a structured way of bringing together key players in community systems to develop strategies and procedures for responding to abuse. CCR offers a holistic approach to addressing IPV and is implemented by local councils of service providers who work together to ensure that victim support organizations effectively work with service providers from other parts of the system to ensure that the holistic needs of victims are adequately met. The premise is similar to MARAC in that it regularly brings together people from different agencies. However, CCR steering groups are larger and include service providers along with other professionals, community members, and stakeholders. CCR identifies strategies for improving the community's ability to intervene in a way that ends abuse. CCR focuses on the system's responses and practices, not necessarily on individual cases. Even though both MARAC and CCR offer effective frameworks for multi-agency cooperation, neither specifically addresses the issue of recurring IPV and PSU. Both frameworks aim to create a better response to the needs of IPV survivors. An alternative solution to address the needs of female survivors of IPV with PSU is to design a service specifically for them that can offer integrated intervention. The Metzineres shelter in Barcelona that was founded in 2017 is a good example. Metzineres is the first NGO to offer a comprehensive harm reduction program exclusively for women survivors of IPV in Catalonia. They offer a holistic and individualized approach for women, trans people, and non-binary people. Their client profile is very diverse. According to a 2020 interview with one of their founders, Aura Roig, the youngest client was 18 years old and the oldest was in their 70s. Comprising more than 25 nationalities, more than 40% of the clients have experience as migrants, more than 60% are unhoused, most have been incarcerated, and some have lost custody of children. Of course, all have experienced problematic situations arising from drug use, and as a result, many have experienced multiple violent situations. Metzineres has a small, all-female team with very diverse backgrounds. There are 2 experts in drug policy, gender mainstreaming, and harm reduction, a project officer specialized in law, a doctor, a social worker, a social educator, a nursing assistant, and Kundalini yoga workshop facilitator, a social integration specialist who is also a graphic artist and designer, and other workshop facilitators. There are also volunteers, interns, and neighbors who offer their collaboration and skills. The organization makes a special effort to respond to the needs of the women they serve. For example, women with PSU are vulnerable while sleeping on the streets, as there is always a risk of being raped while intoxicated. That is why Metzineres offers a safe shelter where women can rest during the day. They also have showers, washing machines, clothes, and lockers. Metzineres also invests in integrating the women into the community. They host different cultural events and workshops, including dance and yoga classes, photography, and self-defense trainings. Every Friday, women in Metzineres cook paella with their neighbors. Through these and other efforts, Metzineres pays attention not only to the problem of substance abuse, but also to issues associated with it, such as the risk of violence, stigmatization, becoming homeless, and losing custody of children. However, one NGO offering integrated intervention cannot address all the problems of female survivors of IPV with PSU. In addition to psychological support and counseling provided through an integrated service, women might need to interact with other organizations and social services, including local government, government unemployment service, women's support centers, social insurance, police, and their family physician and other medical specialists. Thus, no matter which intervention model is selected, successful multi-agency cooperation requires awareness that collaboration is needed, decision-making on whom to work with, appointed members who are committed to the team, a common definition of IPV and PSU, and a common vision for cooperation, a clear and efficient work structure for the team that clarifies who does what and the precise rules and procedures, a holistic method for referrals, integrated maintenance options, clear protocols and methods for sharing information, consultations for specialists, and specific training for health and social care professionals on how to respond to cases of domestic violence with PSU. Building strong and effective multi-agency cooperation takes time and confidence, and there may be several obstacles such as lack of awareness of multi-agency cooperation, lack of commitment from management or staff, each agency striving to maintain its autonomy and independence, different organizational cultures, organizational procedures that are difficult to synchronize and coordinate, organizational goals that are different between partners, different expectations, competition for management and/or resources, and lack of trust between agencies. Nevertheless, there are factors that are known for fostering successful cooperation. They include shared vision and goal setting, understanding multi-agency collaboration models, trust and goodwill between individuals from different agencies, management's trust and goodwill towards the project, and allowing sufficient time and resources for cooperation if applicable. We've come to the end of the lecture. Thank you for watching. We hope this online course was useful. Feel free to share it with your colleagues or anyone interested. This course was based on the FAFSA training curriculum, which can be found in this week's materials. You can also check out the FAFSA project website, where you can download different materials for free on the topic of IPV and PSU. Stay safe and goodbye.